So number one, I think we don't have a standardized diagnosis of neurogenic TOS. There are many variant forms of the anatomy and many variations of the dynamic changes that occur when you move your arms. And I think that the tests we have been shown, for example, clinical tests like Ruse test or the Wright test or Adson's test. Some of these, like Adson's test, rely mostly on changes in blood flow. And there are many, many patients with neurogenic TOS who have no alteration of blood flow. So Adson's test, as good as it was in the 1920s, is really of little use today, but many doctors still associate that as one of the primary tests for neurogenic TOS. However, tests like Adson's and the Wright test and Ruse test, they've been shown to be very poor, either low sensitivity or low specificity when you look at patients with neurogenic TOS. So these clinical provocative tests where your doctor moves your arm into various positions, asks you to take your breath, turn your neck, like Adson's, like Ruse test, they're not that great. And even if they are positive, they don't show anything about the underlying anatomy. Keep in mind, we know from 200 years of surgical studies and dissection studies that patients are very different from one another in their anatomy. There are many variations in the brachial plexus and the muscles and the fibrous bands and even the shape of the ribs in patients with TOS. And in patients without TOS, just normal humans have anatomic variation where the neck and the chest all meet together. So imaging tests are critical for that, and I'd like to see that standardized. Along the course of that, the second thing I think we might add would be better correlation between surgical findings and diagnostic tests. I haven't mentioned EMG before, or nerve conduction velocity. These are called electrophysiologic studies, and they used to be used a lot. One person actually used them to create a category of disputed TOS because the electrophysiologic studies were negative. And that's crazy because electrophysiologic tests are negative in most patients with TOS. However, they are positive in some patients. And during surgery, rarely, some researchers have actually looked at the nerves of the brachial plexus in surgery where they can get much closer rather than down the arm where the whole signal is diluted. And they have found abnormalities of those nerves right at the brachial plexus, right where they pass over a fibrous band, for example. So I think there is value in correlating surgical findings with diagnostic tests like electrophysiologic tests and MRI. Now, MRI has been shown in the literature to be very accurate in showing the thoracic outlet, but surgical correlation would be a step beyond that and would be very useful. That means patients have to have a protocol where they get MRI imaging and maybe electrophysiologic studies before surgery, and then the surgeon and radiologist discuss the findings that are found at surgery to correlate. And then third, I think that for patients who fail surgery or have recurrent symptoms, it would be great to have postoperative imaging. I do see a few of these cases that come to me because the patients are in a lot of pain, or the patient sees a new doctor and the doctor says, the surgery doesn't seem to have helped. Can you image and show me what's going on? And we have found some surprising things. So many of the surgeons who perform this kind of surgery don't get imaging before the test, and they're unlikely to get imaging after the surgery. So 3 things that I think could help patients. Number 1, standardized diagnosis. Number 2, surgical correlation with diagnostic tests to understand how well they work. And number 3, more postoperative imaging to understand why some patients fail or recur.